been working with Mr. Najjar and Chinadu as well. So I'll just share my screen and we can get started. Hopefully you can see my screen now.
Yeah, we can.
Perfect. So just start off with a few learning objectives for this short talk. So starting off with why it actually matters. It's all well and good doing a systematic review, but being able to interpret what you've done in the methodology in the write-up is critical, because that actually infers what your recommendations are at the end of it. Systematic reviews are the top level of evidence, particularly systematic reviews of randomized control trials, which is level 1 evidence. Understanding heterogeneity is important because this tells you whether it may be appropriate or not appropriate to pull the data. It's always tempting to think, I've done a systematic review, I want to pull the data so I can do a meta-analysis. But sometimes it's not appropriate, and understanding heterogeneity is really important for that. And then obviously interpreting the forest plots to inform your recommendations as well. That's really critical. So starting off with, why does it matter? So this is going to be somewhat of an interactive session, so it'd be great if you could unmute and speak up. So before I reveal some of the reasons that I thought of, do one of you want to shout out why you think interpretation matters? If not, I will. You see, you've got your camera on, so I'm going to be mean and ask you for anything that you can think of.
I mean, to make sense of the data that you've collated and the trials that you've looked at and you've screened, I guess.
Yeah. Can you think of anything else?
I'm not too sure, but I mean, without interpretation, you wouldn't have any meaningful outcomes, or you know.
Yeah, exactly. So yes, so interpretation leads the results onto the discussion, which leads to the final conclusion and recommendations. But also, sometimes you have to determine whether something's just statistical difference, and then put that in the context. So sometimes statistical difference doesn't mean clinical difference. So it's all well and good reading a p-value, but that might not actually influence the way you treat patients. So that's the first point. And over-reliance on pooled estimates can mask important differences. So that statement is referring to the fact that when you're pooling studies, they take weights of different studies, especially when you're combining studies of different designs. There can be an over-reliance on retrospective studies, which have a larger sample size. So it's just important to take the context into consideration when you're analyzing the results. I mentioned the term heterogeneity. Do either of you guys know what heterogeneity means?
I understand it as variability, but I don't know if I've got like just differences and it says it there, high variability.
Yeah, no, that's exactly right. And do you know how studies can vary?
I mean, you can have like RCTs versus, I don't know, case studies and retrospective ones. And so you can have different types, I guess.
Yeah, absolutely. So you can have differences in study design. You can have differences in population as well. So one study might be looking at kids' scoliosis. Another one might be looking at adult spinal deformity, things like that. And also the methodology of the study as well. So that's one type that we mentioned. The other type is statistical heterogeneity, which is how much do the results of the different studies vary in themselves. And there's something called an I-squared statistic that we will touch on soon that discusses purely statistical heterogeneity. We've discussed this briefly about clinical versus statistical relevance. And ultimately, as we said, that is the whole point, is in order to support evidence-based decisions. So now here is a big question. It's whether to pool results, and it ultimately comes down to heterogeneity. So we mentioned the different types of heterogeneity. You can have differences in the populations, the comparisons that are being done, and in settings in the studies included in a systematic review. Differences in study design constitute what's termed as methodological heterogeneity. Variation in effect sizes, so that's the different study results that you would see on a forest plot, for example. That's the statistical heterogeneity. And the higher the heterogeneity, the reduced confidence and the higher variability there would be in the final pooled estimate. So that's assessed with the I-squared statistic. That's on a scale from 0 to 100%, where the lower the percentage, the lower the variability between studies, and the higher the reliability of the pooled estimate at the end of it. And so I've created a rough 6-point framework when analysing any forest plot. So the first step is make sure that you know what's being compared. So it's intervention A versus control for maybe operative time being the outcome. Then before you look straight down to the pooled estimate, it's good to just briefly scan what are the different studies reporting that outcome showing. Are 3 studies showing favouring the intervention and 3 studies favouring the control? And then the pooled estimate might be one way or the other or no difference. And then check the study weights. So there's different weights that you can give to studies. The most commonly used, typically inverse variance, which basically reflects the number of participants in each study, and can be demonstrated on the size of the square in the forest plot, and I'll flick to it on the next slide. And then the pooled estimate at the bottom is the diamond, and that basically sums together the effects of the studies, weights them according to the sample size and the effect sizes, and gives you an overall pooled estimate. And then you compare that diamond to the line of no effect. I'll show you that on the next slide as well. And then the heterogeneity of the I-squared statistic to put it into confidence. How reliable actually is this analysis? And it also informs, after looking at the I-squared, you can go back to refine if you didn't pre-specify whether to use a fixed or random effects model of meta-analysis. But typically this should be specified before starting the review. So for the first one, just to go through the 6 bullet points. So number 1, it's a comparison between power and manual assisted screw placement, and it's looking at the outcome of operative time. So that's step 1 here, identify the comparison and outcome. Step 2 is individual studies. So do one of you want to have a go at saying what do each of the 3 individual studies, what is the effect size and what can you infer?
I'm not entirely sure. I would like, if you go through one of them, then I think I can understand better.
Sure. So the square where they are, that marks the individual study estimate. But like with any estimate, there typically is, as it says, there's a confidence interval in which statistically the mean is likely to fall between. So as you can see, the width of these lines represents the confidence interval for each estimate. So here's the estimate of each one. You can see that they all cross 0 in these numbers here, and all the lines cross the line of no effect, which is the line upwards above the 0. So none of the results of the individual studies is significant. Hopefully that makes sense. If it doesn't, just give a shout.
Can I ask why is this square? So you said the square is the mean of the data, estimated mean. So why is it different size?
So so looking at the third point, just moving on to that, that's the size of the square represents the sample size, typically. And as you can see, the total sample size here is the largest. So 283 plus 159 is greater than those numbers added and those numbers added. And that's why this study is weighted the most in the analysis. Does that answer your question?
Yeah, thank you.
No worries. And then moving on to the fourth point, now it's looking at the pooled estimate at the diamond at the bottom. So that's the pooled estimate. As you can see, the sort of the center of the diamond is slightly to the left, but it overlaps the line of no effect. So that's 0.5, compare it to the line of no effect. There's no significant difference, is what you would say. And the p-value is 0.69. Hopefully you can see that there. So typically 0.05 is used. So if it's greater than 0.05, there's no significant effect. And the final point is to look at heterogeneity. So it's 34%. So typically, the lower the I-squared, the lower the heterogeneity, the more reliable the estimate. Obviously, you do need to take into account the clinical factors and methodological factors of the studies. This is purely statistical heterogeneity, but this is often used to guide which model of meta-analysis you use. So this is quite low. Typically, a threshold of 50 or 75 is used. And because it's less than 50, we've used a fixed effects model of meta-analysis, because it's saying that the differences between the effect sizes between studies are quite similar. So we can use a fixed model. If there's quite a lot of difference, then statistically or methodologically, then you'd use a random effects. And if, let's say, you're doing a study where you're expecting a lot of heterogeneity in the studies, even without looking at the statistical heterogeneity, you would decide to use a random effects model, because that slightly modifies the weighting that's given to each of these studies. So now I've got another example.
Sorry, could you repeat the last thing you said about modifies the model?
Yeah, so the weighting of the studies is affected by three factors. One is the sample size, one is the effect size, and the third is the model used, so fixed or random effects. So if there's high heterogeneity, you want to use a random effects model, and that basically reduces the weight given to the largest study. So if you look at a random effects model, typically the study effect sizes are more spread out between the studies because there's high variability. But if they're all quite similar, you can give more weight to the larger study, essentially. That's the principle. So for the next one,
sorry, Neil, just to take you back. Now, when Neil mentions heterogeneity, it's the I-squared. Just show them the I-squared and what marks the heterogeneity and how you would know what values suggests a high heterogeneity and what values suggest no heterogeneity in between the studies. Just take them through that, please.
Sorry, could you repeat that, Chinedu?
You know, the I-squared, just how to determine how the level or degree of heterogeneity within the pooled studies, and then to help guide when you use random and fixed effects. You know, the I-squared down there, the heterogeneity down in your plots. In this case, I-squared is 34%, which suggests in the grading moderates, right?
Yes. So
yeah, just take them through that.
So hopefully you can see this slide. So typically up to 25% is low, up to 50% is moderate, up to 75% is high, and above 75% would be very high. If it's low or moderate, I would typically go for a fixed effects model. But if it's high or very high, then I'd switch to a random effects model. Other thresholds have been used, so some people use 75%, but it's, I think, down to personal preference. But I typically go for low or moderate. Chinedu said it'd go for a fixed effects model, and above 50%, you just random effects model, and it automatically generates. So once you input the numbers, it automatically generates the I-squared, and then you can modify your model size depending on that. So this is the next example. We've been through an example now, so do one of you feel comfortable doing so? Want to go through the 6 steps of analyzing this forest plot?
I've got, sorry, just before I go through that, I've got one more question about the line of no effect. Is that just the line in the middle to suggest whether it's significant or not?
Yes, so for continuous variables, the line of no effect is at 0, so there's a difference of 0 between the 2 studies. So for this next example, it's at 1, and that's because it's a ratio. So a 1-to-1 ratio is no effect. So that's why it's at 1, whereas that one's a continuous variable, so it's at 0. It's always the line in the center.
And in the previous one, you mentioned that it crosses the line. Is it meant to cross right or cross left?
That depends on what the studies are. So if you can see, the largest study is slightly to the left, the square. So this overall diamond, the center is just slightly to the left, which sort of reflects that. But as you can see, the tail on the right-hand side goes over onto the other side. That's why it's not significant.
And then also, just so you're aware, that this particular chart you have on the right-hand side of your screen, it's not being generated by yourself. It's automatic, and it's all based on the values you put in under the mean, standard deviation, and total. So just to buttress on what Neil has said. So for example, in this study, they are looking at operative time difference between a use of power tool or manual, probably screw insertion, right? Now, the mean operative time for Kotani in the power tool was 260. The standard deviation was 47.7, and the total patients were 30. And then you impute the one for manual, and then it gives you this chart for Kotani, and that's the same thing that happens with the other studies and all these other inputs. The one at the computation at the lower part of the graph, including the graph itself, are all automatic. And remember, those things Neil mentioned, it's very important for you to just ensure that you're using the right parameters, if anything. So yeah, you guys will go through the other example, and then let's see.
Who feels comfortable giving this a shot?
I can give it a try if you help me out.
Absolutely.
So it's looking at the risk ratio of screw bridge between power and manual. And then looking at the size of the what do you call it? How separate the risk ratios are. The 2 studies in the middle, they are more spread out, but then the one at the top and at the bottom, they are more close to each other, and they are bigger size population, bigger size of, because the square is bigger, so it's what do you call it? Population bigger.
Large sample size, yeah.
Large sample size, and then your diamond is more towards the left of the one line. However, it still crosses it. So you say, is it not significant? Yeah, something like that.
If you also look at the p-value here, that p-value is greater than 0.05 as well, so you can just check there. And another way to check is if you look at the confidence interval, if it crosses 1, so that this figure reflects this diamond. The center of the diamond is the 0.69. The left-hand point is 0.38 and the right-hand point is 1.25. I say that's perfect. And the last thing to assess is the heterogeneity. So you infer from the heterogeneity and explain the model used.
I don't think I can do that.
Okay, no problem.
just to add, since it has 73, that it's less than 75, but I still say it's a high. So a random risk ratio model is being used because
random
the
effects model.
random
Exactly.
effects model.
Perfect. Well done, guys. And then one more example of this type for someone else to have a go. And this is in relation to positive culture rates for biopsies.
Shall I give it a crack?
Absolutely.
So, are we first looking at the risk ratios? So we've got different studies, and in this case, the total diamond you've got doesn't cross the center, so we've got some statistical significance there. The confidence interval doesn't cross. In terms of the population sizes as well, the sample sizes as well. What do I need to mention about the sample sizes? Because they're already kind of...
Yeah, there's not much to say about them. There's lots of different studies here.
Yeah, different studies. The p-value is less than 0.05. And the I-squared value is 0%, so we can definitely use the fixed model in this case. I didn't go through the 6 domains, but yeah.
That's everything. Yeah, so it's comparing antibiotics and no antibiotics for positive culture rate. If you just look at the individual study estimates, they're all slightly to the left of the midline, a few slightly further left. But this really reflects, the reason I chose this plot is it really reflects the power of meta-analysis. So for most of the studies, they're not significant or sort of just significant. Most of them cross the line of no effect, but once you pull them together with this overall diamond, it's well over to the left-hand side, and so you can identify that significant result. And that's why everyone wants to perform meta-analyses with their systematic reviews, and that's why it's the highest level of evidence, because it pulls everything together. But sometimes it's not appropriate to pull loads of different studies together like this. Sometimes you might have to break it down slightly. So this was from the same paper, looking at positive culture rates, but looking at when the antibiotic was given and how that influences the positive culture rate. And so at different times, so if the antibiotic was given 72 hours ago, that's very different to whether they were receiving antibiotics over 6 months ago. And likewise, I think there were something like 30 studies in this systematic review. So we broke it down into different categories and said, individually, how is the effect of antibiotics given less than 72 hours, etc., etc. And as you can see, the only one where there was a significant difference was the one at 6 months. But again, in this category, there was only one study, so it's not the most reliable estimate from that. So again, just because you have a significant result statistically doesn't mean that it's a reliable result. So always take into account the sample size of the study. It's quite a small study. Take into account the fact it's only one study. But yeah, you can always break it down. You can exclude high risk of bias studies from the analysis if you think it's appropriate as well when you do the risk of bias. But do consider doing subgroup analysis. And when you do a subgroup analysis, it's important to not have an overall diamond at the bottom that compares all of these different subgroups, because it's not appropriate to combine less than 72 hours with 6 months. Does anyone have any questions about subgroup analysis?
What is subgroup analysis? Is it that you do it individually, or?
Yeah, so subgroup. So an overall group would just be all of these, maybe 20 studies on this on the slide put together into one analysis, and you'd get one diamond at the bottom. Subgroups are essentially that you've got a subgroup of less than 72 hours and you've analysed those studies together. You've got a subgroup of 3 to 7 days and analysed those together, etc.
Just a quick question. With subgroup analyses, are we always using random effect models? Because I can see here the I-squared is only like 14%, but we're still using a random effect.
Yeah, so for the reason that random effects was used was because if you see the largest I-squared value was 78% here.
Oh, I understand. Okay, yeah.
So if any subgroup has a high I-squared value, doing a random effects model is always the safest thing to do.
Got
because it doesn't over-prioritize one study. But I understand why. So this is a test for subgroup differences, which is how does the results of less than 72 hours differ from 2 weeks, from 6 months, etc. Yeah, so the largest one was 78, that's why.
Yeah, and also to buttress on the subgroup analysis. So we use subgroup analysis when there is significant heterogeneity between studies. So for example, just like what Neil has shown here, because we've got about, say, roughly 20 studies, all included, if you pull all of them together, the effects will be probably significant or not significant. However, it would make sense that we then sub-analyze those groups and try to find out what's the difference when the timing is less than 72 hours and, yada, yada, yada. So those are the reasons why we subgroup. So that's when we use it when there's high heterogeneity between studies, which you'd always experience when you pull primary studies from a line. Yeah.
Thank you. And sort of this is just an example of the descriptive analysis of that. So although significance was only achieved in the 6-month group, there was a general trend towards reduced yield in the antibiotic group. I think that's, yeah. So you can see they're mostly towards the left of that, even if there's not significance. And then putting those findings into the context of the wider review, suggesting that antibiotics may negatively impact the cultural yield. But yeah, so comment on significance and then put it into context. But that said, we've discussed a lot of forest plots, but it's important to note you don't always need to pull, especially when there is high heterogeneity. Methodologically, particularly that can't be assessed with the I-squared statistic. You might think that it's not appropriate to pull them in meta-analysis. But what you can do is present them descriptively in a table and discuss them narratively as well. So this was a study looking at the fixation of odontoid fractures in children using an anterior, posterior, or combined approach, and just looking at the complications from each of those approaches. There was significant variation in the populations used, the methodological designs, and just going from the studies, from the data extraction, we summed up the proportion of complications in each of the 3 and compared them using, so in this case, because there were 3 groups, it was a chi-squared test, looking at complication, no complication as the 2 outcomes, and just reported some p-values. As you can see, none of them in here were significant at the 5% level. But that's likely because the sample sizes were so small, especially if you can see in the combined group, there were only 62 fractures in the whole study and only 4 in the combined group which had no complications. So that's quite unreliable with a very small sample size. Especially a lot of the studies in this systematic review were retrospective. So that's another thing to always mention in the limitations of a review, if you've used small sample size retrospective data. And do one of you want to have a go at describing this narratively before I share the description of how would you interpret this data?
I'm assuming each of them is just looking at the complication, right?
Yes, these are all
Okay.
complications. So fusion's a positive outcome. The rest are all negative outcomes.
Sorry, so like, say, for example, like the number of fractures 17 out of 62. Is that
So,
it's a bit small as well, so I'm just trying to
sorry,
no, it's sorry.
make that a bit bigger. So 17 out of 62 just means that 17 of the 62 fractures in the study were treated with the anterior approach. Of which 15 achieved fusion. 3 of the 17 patients had persistence of symptoms, none had neurological decline, and it works throughout the table like that. Hopefully that makes sense.
And out of all of them, the sample size overall was 62.
Sample size overall is 62, that's right.
Okay, so out of the anterior approach, 17 were treated. Sorry, out of the fractures, 17 out of the 62 fractures, 17 were treated using the anterior approach. 15 of which had a fusion, and 3 of them didn't have any persistent symptoms. There were no neurological decline, deep wound infection. Only one of them had a failed fusion. Kyphotic scoliotic deformity, none had any of that. There was one mortality, unfortunately, and 3 of the patients had complications, and none of them had reoperations. Then, not looking at p-value, none of it was significant. And I'm assuming because it wasn't significant, why descriptive statistics were done, because the heterogeneity would have been very high. Or am I going the wrong way?
The second part of that statement was correct. So the reason why pooled analysis wasn't done was because there was high heterogeneity. You don't decide on the heterogeneity based on whether there's significance or not. It's purely due to the heterogeneity. But yeah, that's right. So that inference from this table is perfectly correct. And just sort of comparing the columns, you can see, just as a summary here, the number of patients with complications was quite high in the posterior compared to the anterior combined. And the combined, yes, it had 4, but there were no complications altogether, and all achieved fusion. A very small sample size, so very unreliable to give any firm recommendations, but you can indicate trends with the systematic review as well. This was almost significant as well. But just looking at how this paper inferred the results, they said the combined approach had the most favorable outcomes with no complications and 100% fusion. But again, this bit is critical. Caution due to the limited sample size. Posterior fixation had the highest complication burden, and anterior was somewhere in the middle. And then putting them into context of the wider study and the other findings. Hopefully that all makes sense and shows that you can get something to discuss in the paper without having to need to do a meta-analysis, and the fact that sometimes when there is a lot of heterogeneity, it isn't appropriate to pool the studies. And that's very study dependent. Yeah, that was everything that I wanted to discuss. Are there any questions related to that last bit or the rest of the presentation?
What do you normally do to carrier statistics? Like, what system do you use?
So all the plots shown on here, so this one, these were all done on RevMan, but you can use various other software. You can use R as well. it's whichever one you have access to and you can learn, essentially.
Thank you.
Yeah, very good, Neil. Very detailed discussion on interpretation. And guys, I hope it's thrown a bit of light into understanding systematic review, data set, and how it's being analyzed. It's not so difficult. You just have to just pay attention to some of the details, and you get your way around it. Yeah, very good work, Neil. Thank you very much. That was really good. Does anyone have any questions they want to ask, or all makes sense? Lovely, very good. Let me stop the recording there.